was there, but we're the only ones that had to go.
Hello, Southwest, are you guys there? Southwest is the only one that might be there.
Hi, good morning.
Hi, there you are. Okay. Cat. I got an email, Donna, that, let's see. Brittany's here. Abby's not coming.
What's the video?
Alice is in Donna's office doing her IEC.
Okay. Who else are we missing?
Ashley and Candy.
Okay. I got an email from Candy. There it is. Okay. Okay.
In here, in the next building.
It's in Rob Hall. Do you know where the library is? Go in that back one of the library on the second floor. It's the first door on the right before you get to the library. Normally 1 o'clock. I will do lab early today if you guys want me to. The weather. So just let me know where you all get done with Mr. Lowe, and we'll go to lab at that point. So I'm thinking around 11:30 or so. Okay.
Oh, yeah. I knew it.
It doesn't matter. Doesn't matter.
Hey, Christy, did Polly come on? Dawn was wanting to know.
Yes.
Yes.
All right,
Students,
thank you.
it was apparently already connected by the time I got in here.
Okay.
Okay. Virginia Highlands and Withville are both on a 2-hour delay, so they won't be with us this morning, at least for this class. Hopefully they'll come in for Dawn's class. But I've got some good news and I've got some bad news. Mr. Lowe, thankfully, through many phone calls and emails, he got the issue with the clickers fixed. So I was going to use clickers today, but with a delay of 2 campuses, it's not fair to do that. So hopefully by next Tuesday we'll be able to begin using clickers. So you guys will be able to get some points for that. So make sure you bring those with you. And for those of you watching this as a recording, make sure that you bring clickers with you the next time we have class. So we can't use them today, but we will begin using those hopefully next week, if all goes well. I'm sorry?
He asked me about that link, and he asked me where he watched it.
Oh.
I've never got mine to work.
If you have that issue with the link, you need to email, either email me or Mr. Lowe. Sometimes with those links, if you click them, they'll immediately open up and play, depending on, I don't know if it depends on your web browser, or if it depends on, I'm not sure. But sometimes for me, when I've tried to view them, you click on the link and it automatically opens up and plays. Other times I've had to copy paste that link into a web browser. And sometimes that worked. If that doesn't work, let us know. And we can get a hold of somebody to try to help you. Because that's all we're provided is that link. I mean, we don't have any more to do with it than you. Any question? We're going to try and finish chapter 7 today. You guys will go over all of chapter 7 in lab today, and your test, for weather permitting and time allowed. Your test on Chapter 7 and your Chapter 7 homework will be next Tuesday, so the next day we're back in classes. I don't have any idea what the weather's supposed to be next Tuesday. If there is weather issues, then just check your email. But as of right now, we're going to finish Chapter 7 today, and then I was going to use the extra time to do clickers, but, we'll do that another day. I'm not going to start Chapter 8. If I finish Chapter 7 early, I'm not going to start Chapter 8. Excuse me, before the break. But does anybody have any questions about anything in Chapter 7 so far? Okay. Okay, a bilateral frog leg position. For a hip, if you get an order for a hip, typically what you're going to do is an AP, which is a proximal femur, and then a lateral hip, which is also known as a frog leg. If you get an order for bilateral hips, then this is the lateral that you're going to do for that, is a bilateral frog leg projection. And it's basically a pelvis radiograph, but your legs are positioned differently. If it's for a pelvis, then you want to make sure you include the iliac crest, the positioning as far as the SID, the technique, the central ray is 40-inch SID with a perpendicular central ray. All of that is the exact same as the AP pelvis from page 277. But your central ray enters 3 inches below the ASIS, which is a little bit lower. For a bilateral frog leg, you're not so much concerned about the top of the pelvis, so you can clip the iliac crest a little bit, but you're more concerned about proximal femur and the acetabulum area and the lower pelvis. So you can clip the top of the iliac crest and that'll be fine. You're still going to use a 14 by 17 inch image receptor crosswise because you want both hips, both proximal femurs on one image receptor. But what you're going to do with the patient's legs is you're going to bend the knees up, and in essence you're going to let their legs fall out to the sides, like you see in this picture. Now, if some patients will be able to put the bottoms of their feet together, like you see in this inset picture, and they're going to abduct their legs 45 degrees out. So their legs aren't straight up in the air. Their legs aren't laying all the way over to the side, which most patients will not be able to do anyway. They're not that flexible. But their legs are out in the air about 45 degrees. The one thing you need to make sure on this projection is that your pelvis is not rotated, and in that, both legs need to be, the knees need to be bent the same amount, the legs need to be abducted the same degrees. If one knee is bent higher than the other, or if one leg is abducted more than the other, your pelvis and your hips are going to be rotated. So both legs need to be doing exactly the same thing in order to ensure that your pelvis is not rotated. And this is what you see. You see the majority of the pelvis. You see proximal femur down below lesser trochanters. The greater trochanters and femoral neck are going to be superimposed. You do see lesser trochanters. And with equal abduction of the legs, unless there's pathology there, the proximal femurs should look the same. They should be symmetrical. You want to make sure it's not rotated, and again, you can look at that by looking at the iliac wings and the obturator foramina. They should be symmetrical. If they're not, then you have rotation. If there's elongation of the iliac wing, then you're rotated toward the side that's elongated. This is also known as the modified Cleaves method. Now, generally, you do that 40 to 45 degree abduction of the legs. If you're looking specifically at femoral neck, you're only going to do 20 to 30 degree abduction. And that's something either that your physician has said on the order. It said, attention femoral neck area. So you'll know to do that 20 to 30 degrees instead of 40 to 45 degrees. Or maybe it's something you have seen on the AP pelvis or the AP hip, something you've seen on another image. The Taylor method, outlet projection. This is looking at the pubic bones and the ischiums, typically for some kind of trauma. A 14 by 17 inch image receptor crosswise. About an 80 to 85 kV is what your book says, and you're still looking at about 25 mass. You use automated exposure control. You want to use the center detector area because that's where the anatomy is that you want to see. You lay your patient supine on the table. You can leave their legs straight out, or you can support them to make them that sponge under their knees, or that wedge under their knees makes them feel a little more comfortable, a lot of patients, especially if they have back problems already. Your central ray is going to be angled. This is an axial projection, so your central ray is going to be angled. 20 to 35 degrees cephalic for males and 30 to 45 degrees cephalic for females. And this is because the difference is in the shape of the male and female pelvis. Your central ray enters 1 to 2 inches distal to the superior border of the symphysis pubis. So it's the superior border of the symphysis pubis, not the middle of it, not the bottom of it, but the superior border. This should be inside the bucky. You do need a grid for this. And this is not something you're going to be able to shield a patient for. You may be able to shield a little bit for females, but definitely not males. But again, it's got to be placed very carefully so you don't cover up anatomy. But this is what it looks like. Your pubic bones and your ischial bones are elongated. They look like they're stretched out. The obturator foramina is elongated. And you want to see all of these bones here, the pubis and the ischium. You want to see all of those. You want to see a little bit of proximal femur. You don't necessarily need to see greater trochanters because you're not looking at hips. This is for the ischium and the pubis bones. And you don't care about SI joints. You don't care about ilium. You don't care about iliac crest. So all of that can be clipped. Well, this area right here, and it's going to look like somebody's just stretched out a pelvis. You want to make sure they're not rotated, and you can do that by looking at the obturator foramina. They should be symmetrical. If they're not, you've got rotation. If you look over on page 281, now we've talked about the iliac wings, and if they're elongated, then that's the side that you're rotated toward. But on this image, on the outlet projection of the pelvis, you don't see iliac wings, but you do see obturator foramina. So when you're looking at obturator foramina to determine rotation, if one is more closed than the other, then that is the side you're rotated toward. So look on page 281, figure 7-58. The right obturator foramina is closed. That patient is rotated toward the right side. That right iliac wing is elongated, the right obturator foramina is closed. So that patient is rotated toward the right side. In 7-59, the right obturator foramina is way open. So that patient is rotated away from the right side. If the obturator foramina is open, that patient is rotated away from that side. So that patient in 7-59 on page 281, that patient is rotated toward the left side. So the right obturator foramina is open. And that's how you can tell rotation on this apiaxial outlet projection, the Taylor method, is by looking at that obturator foramina. Both of those foramina should be symmetrical. If they're not, which obturator foramina appears more open and which appears more closed? And that's how you tell which way it's rotated. Any questions about that? Okay, an apiaxial inlet projection. This, again, is looking for trauma, but it's looking for a different area of the pelvis. This is looking at the anterior pelvis, looking at iliac wings, you're going to use a 14 by 17 inch image receptor for this. And your book says if you're using automated exposure controls, you use the outer two cells, which would work because they would be centered over the iliac wings. About an 80 to an 85 kV, and again 25 to 32 mass for an average patient. The 40-inch SID, and your central ray is angled 40 degrees caudal, and it enters at the level of the ASIS. It ends up being perpendicular to that plane of the inlet. That's why this is called an inlet projection. The central ray ends up being perpendicular to that plane of the inlet. And this is what it looks like. You want to see as much of the entire pelvis as possible. And the whole pelvis looks like it's stretched out. And that's because the whole pelvis is elongated. And that's because of the angle on the central ray. You want to see the ischial spines. The inlet should be centered. You're going to see a little bit of proximal femur, but not a tremendous amount. It says on the PowerPoint, lateral collimation evident. You're really not going to be able to collimate much, if at all, laterally, especially on an adult patient, because you want to see as much of that pelvis as possible on this. So the outlet method, you're looking at anterior, inferior pelvic bones. The Taylor method is looking at pubis and ischium. The outlet projection, inlet projection, you're going to see the whole pelvis. Okay, for acetabulum, if you get an order for an acetabulum, you're going to do the Judet method, and you're going to do 2 projections. Possibly also the Tufel method that's on the next page. But if you get an order for an acetabulum, most of the time, that patient has already had regular hip x-rays or a pelvis x-ray or both. And the physician maybe sees something in the acetabulum area they want to look at more closely. Now, granted, these are not done tremendously often, because a lot of times if they see something in that hip or pelvis area on the plain x-rays, they're going to send them to CT a lot of times. But in cases where maybe the physician is concerned about radiation exposure, then these x-rays are a lot less radiation exposure than a CT. Maybe the patient's had a lot of other CT abdomen pelvises for other things, then they don't want to expose them anymore to CT. Or maybe the patient doesn't have insurance and they're private pay. X-rays are a whole lot cheaper than CT. So there's various reasons that you may still do these types of projections. For the Judet method, this is a posterior oblique pelvis looking at the acetabulum area. Now, your book gives a couple of different image receptor sizes. A 10 by 12 inch done lengthwise, centered over one acetabulum at a time. And in doing a 10 by 12 inch image receptor lengthwise and one acetabulum at a time, you're going to end up doing 4 projections in the Judet method. You're going to position the patient in a right posterior oblique. These are 45-degree obliques. And you're going to do 1 projection centered over the acetabulum that's elevated and 1 projection centered over the acetabulum that's down. Then you're going to put them in the other oblique and do the same thing with a 10 by 12 inch image receptor lengthwise. These are about an 80 to 85 kV and again 25 to 32 mass. When using a 10 by 12 inch lengthwise, When you're doing the side that's elevated, your central ray is perpendicular to the image receptor. For the elevated acetabulum, you're going to put your central ray 2 inches distal to the elevated anterior superior iliac spine. And what this shows is the posterior rim of the acetabulum and anterior portion of the iliopubic area. So the side that's up shows posterior rim of the acetabulum and the anterior iliopubic area. And the central ray enters 2 inches distal to the upside ASIS. For the acetabulum that's down with the patient in the same oblique, your central ray enters 2 inches distal and 2 inches medial to the anterior superior iliac spine that's down. So it's 2 inches distal and 2 inches medial for the downside. That shows the anterior rim and the posterior ilioischial column. And again, using a 10 by 12 inch image receptor lengthwise. Now, if you're using a 14 by 17 inch crosswise, you can get both acetabulum on one image receptor. You're still going to center 2 inches distal to the ASIS, but you're going to center more medially to the body so that your crosswise 14 by 17 will get both acetabulum on one projection. And you're going to get an upside and a downside on one image projection. Then you're going to rotate them to the other oblique and do that again. Again, centered 2 inches distal to the anterior superior iliac spine, but more medial in the body, so you see both acetabulum. And this is what you see. Rotated left posterior oblique is what this image is. The right iliac wing is foreshortened. That's how you can tell the right iliac wing is foreshortened. So this patient is in a left posterior oblique. The right obturator foramina is open, so that patient is in a left posterior oblique. The posterior rim, anterior portion of the iliopubic column is right here. And this is the same image that's in your book on page 281. For the downside, you see an elongated iliac wing for the side that's down. You don't see an obturator foramina, it's closed. See the anterior rim here. Now, if you are doing both on one image receptor, on a 14 by 17, you, as we've told you before, you mark, as far as an oblique, you mark the side that's down. If you're doing both acetabulum on one image receptor, you mark the side that's down. However, if you're only doing a 10 by 12 inch lengthwise, you're only going to get you mark the acetabulum that you see. So, for example, this patient in this image right here on the left, this patient is in a left posterior oblique position, but they're x-raying the acetabulum that's up. So you have to mark this with even though this is a left posterior oblique, you're only seeing the right acetabulum. So this has to be marked with a right marker because this is the right acetabulum. You treat this as you do an extremity. You're only doing one side. So you have to mark the side that you see. Even though this is a left posterior oblique position, and historically we've told you if you do a left posterior oblique, you mark it with a left marker. But in this case, you are in a left posterior oblique position, but you're centered over the right acetabulum, and that's the only acetabulum that you see. So you have to mark this with a right marker. Does that make sense? Okay. Now you also have the Tufel method, which is a PA axial oblique projection, and these patients are in anterior oblique positions. It's a PA projection. It is an axial oblique, so your central ray is angled 12 degrees cephalic. And with the PA axial oblique projection, the Tufel method, you center over the acetabulum that's down. So this patient is in a 35 to 40 degree anterior oblique position. You're going to use a 10 by 12 inch image receptor lengthwise. And again, about an 80 to an 85 kV and about a 25 to 32 mass. Center cell for automated exposure control. Your central ray is angled 12 degrees cephalic, and it enters an inch superior to the greater trochanter that's down. This is also another one that's very, very difficult to shield for. Your book says shield radiosensitive tissues, outside region of interest, but it's very, very difficult to shield gonadal regions for this. Very difficult. They should suspend respiration, and you're going to do both obliques. You're going to do a left anterior oblique and a right anterior oblique and show both acetabulum. They're going to compare the two, and this is what it looks like. It's because of the oblique of the body and the angle on the central ray, it's going to appear elongated. And that's okay. But you're going to see greater trochanter, you're going to see elongated femoral neck and head. Right here's the acetabulum. You're also going to see a little bit of sacrum and coccyx, and that's okay, but it's going to be, with the rotation, it's not going to be superimposed over the anatomy you want to see. A little dip right here. It's hard to see on this image, but you can. It's kind of drawn in on your book. The fovea capitis is right in here. Like I said, it's hard to see on this image, but it's drawn in your book. You see ischial tuberosity, so you should see all of this anatomy here. And you mark, again, with this side, you're marking the side that you see, which is the side that's down in the anterior oblique position. And for acetabulum, a lot of places you're going to do Judet method and Tufel method. It shows the acetabulum in slightly different ways.
Christy,
Yes, ma'am.
there's a couple of questions here, I think.
Okay.
The last one, the Juday method, was 4 projections. What are those?
Can you repeat that question, please? I'm sorry.
The last method that we did.
For the Juday method, or
Brittany gets
Okay, let's try this again. Did you somebody heard this better than I did, I think. Did you ask the 4 projections for the Juday method? Is that what you asked?
Yeah.
Okay. For the Juday method, if you're using a 10 by 12 inch image receptor and you're only doing 1 acetabulum at a time, okay, that's where you're going to have 4 projections. You're going to put the patient in a left posterior oblique position like you see here. You're going to do 1 projection over the side up and 1 projection over the side down. So that's 2. Then you're going to rotate the patient and put them in a right posterior oblique position. And you're going to do 1 projection over the side that's up and 1 projection over the side that's down. So there's your 4.
Okay. And you use
Does that make sense?
Yeah.
Okay. If you're using a 14 by 17 inch image receptor crosswise, then you're only going to have 2. You're going to have 1 with the patient in a left posterior oblique position where you see both acetabulum, and then you do 1 with the patient in a right posterior oblique position where you see both acetabulum.
Is there a picture of that anywhere?
No, I'm sorry.
Okay.
The only difference is when you're using a 14 inch by 17 inch, it's crosswise. You're still going to center at this level here, but instead of being over the acetabulum that's either up or down, you're going to show them both on 1 image receptor, so it's still at this level, but it's going to be more like midline of the body. It's still going to be at 2 inches distal to the ASIS, but it's going to be midline body. Just about. Does that make sense?
Yeah.
And you can see that better in lab.
Okay. I got a little confused.
That's okay.
At 17, you only do
You see both. For the 14 by 17 inch crosswise, on this Juday method, you're going to see a side up and a side down with the 14 by 17 inch crosswise, because you're gonna get both acetabulum on 1 image receptor. So you see a side up and a side down. Does that make sense? And really, whether or not you use a 10 by 12 and do 1 acetabulum at a time, or whether you do a 14 by 17 inch crosswise, you're going to see the same things. It's just whether you do it in 2 projections or 4. It's going to boil down to radiologist preference. Some radiologist is going to say just do 2 projections and save exposure. Some radiologist is going to say I want that 1 acetabulum that I'm looking at centered on that image. So you're going to end up doing 4. So, I mean, both ways are correct. You're going to see the same thing, but it's going to depend on your radiologist preference. Any other questions? Okay. Yes, ma'am. I'm sorry?
Ashley is here.
Okay, thank you. Okay, for a hip. If you get an order for a hip, it means proximal femur. You're going to do an AP projection of the hip, and you're going to do a lateral projection of the hip. So you've got 2 projections. Now, some facilities will throw in an AP pelvis with this too, and that's okay. But for lab purposes, a hip order is an AP hip of the affected side and a lateral hip of the affected side. But know that, as with anything else, some facilities do have their routines slightly differently. And again, that's radiologist preference. For a hip, you're going to typically get an order for a unilateral hip, right hip, left hip, whichever one is hurt. And again, remember, when you get an order for a hip or pelvis and it's trauma, you need to look at that patient's feet. Is one leg shorter than the other? And if that leg that's shorter than the other is the one that they've hurt, that indicates there's a fracture there. Is one foot laying just abnormally externally rotated, just all the way over on its side, when the other one is kind of natural, sticking straight up, or even a little bit externally rotated? But the one that's hurt, is it laying way externally rotated? Then that's also an indication of a fracture. And in that, you would not want to manipulate that leg until you take an image as it lays. Don't ask them to move it at all, and take an image, and you see it or you show it to a physician. But routinely, if they can move it, if they're walking on it, if they've been hurting for 6 months and decided to come to the ER at 3 o'clock in the morning, just whatever. If it's routine and it's not anything that's recent major trauma that they can't move it for, then you do want to manipulate the leg into the proper position. You're going to use a 10 by 12 inch image receptor lengthwise. With a grid, about an 80 to 85 kV range, and again, about 25 mass. Again, depending on patient size. Patient's going to be supine, make sure they're not rotated, and these you should shield for, males and females. You can shield males and females. You're not going to, with a unilateral hip, you don't need to see both hips. You don't need to see the entire pelvis area, so you can shield males and females for these. This is a perpendicular central ray, a 40-inch SID, and yes, it's a grid. And you're going to center your central ray to the mid-femoral neck region. Remember back at the beginning of the chapter, those 2 ways that you can localize femoral necks. It's on page 269. Where you find the ASIS and the symphysis pubis go midway between the two, and then a perpendicular line from that. 1.5 inches is the head of the femur, 2.5 inches is the neck of the femur. Or the other method is find the ASIS, go 1 to 2 inches medial and 3 to 4 inches distal, and there's your femoral neck. This exam here, this AP proximal femur, this is where you use that, because you center for a proximal femur to the mid-femoral neck area. And those localization techniques on page 269 are 2 ways you can find that femoral neck. Because a femoral neck is not anything you can palpate, it's not anything you can see. You can palpate greater trochanter, which is going to get you close to a femoral neck. But even that's gonna be difficult on some patients depending on their size. If they're huge, if you've got a really large patient, it's going to be sometimes hard to palpate that greater trochanter. So these other 2 methods are 2 ways that you can find femoral neck on everybody. You want to internally rotate the affected leg 15 to 20 degrees. This will make sure that you see the femoral neck well, which is where a lot of the fractures happen. Then that femoral neck area. Greater trochanter will be in profile. Lesser trochanter with that internal rotation you will not see, or you will see just a little bit. You want to see about a third of the proximal femur. You want to see a little bit of ilium, a little bit of ischium and pubis. Some facilities will want you to go over to the symphysis pubis, want you to include that, and that's okay. And of course you mark the side that you're doing. If you see a lot of the lesser trochanter, then you did not internally rotate that leg. Now, if a patient has a prosthesis, and I don't have a picture of that for the PowerPoint, but like you see on page 283 in figure 7-66, if a patient has a prosthesis, they've had previous surgery and they have a rod going down their leg, if they have hardware, then remember we talked about this in an earlier chapter. If they have hardware, then if you don't see all of that hardware on this AP hip that you just did, if you clip the bottom of that prosthesis, then you have to go back and do a longer image receptor, or maybe, a 14x17 lengthwise, or do a 10x12 but just do it lower. But either way, you have to see all of that prosthesis and a little bit of bone underneath that prosthesis. A little bit of bone just distal to the end of that prosthesis. Because sometimes if they re-injure that leg, the prosthesis won't break most often. I have seen, but very rarely. But most of the time that prosthesis is not going to break. But if they have another fracture, it's going to be just distal to the end of that prosthesis. So for hips, you have to see the end of that prosthesis. And sometimes you're going to get them on a 10x12 lengthwise. Sometimes they're relatively short. Sometimes they're long. So you'll see techs ask patients before they do hip x-rays, a lot of times, especially elderly patients, as they're talking to them and getting their history, have you ever had hip surgery? And if they say, yeah, I've had a broken hip, then they will automatically go ahead and get a 14x17 inch image receptor so that they make sure they get the bottom of that prosthesis. And that's okay. Sometimes you can see, if you see the lateral edge of their legs, sometimes you can see a scar, where they've had surgery. And you can look at it that way. If your patient can't talk to you, then you can look for the scar. Because there's typically a scar down just the lateral side of their leg where they've had that surgery. But you always have to get the bottom of that prosthesis, even if it's halfway down their femur. Or even if you have to see more than the proximal third of the femur to get the end of that prosthesis, you have to see the end of that prosthesis. Now, there's your AP. For a lateral, we're going to skip this one, and we're going to go to page 285. This is the routine for your lateral hip. For non-trauma, somebody that can move their leg, this is your routine projection for a lateral hip. It's a modified Cleaves method. It's a unilateral frog leg projection. So you're going to do the same thing. You're going to bend that patient's knee up and abduct their femur 45 degrees. So let it fall out to the side. Let it roll out externally. Now, if you want to see femoral head and acetabulum, have them do it 90 degrees. But as a general routine, it's a 45-degree abduction. The same kV in mass as the AP femur, about 80 to 85, about 25 mass. Your central ray is perpendicular to the image receptor, and it goes to the mid-femoral neck area, just like the AP hip. Should shield respiration, or should suspend respiration and shield these patients. And this is what you look like. You want to see the entire femoral head. You see a little bit of neck, but greater trochanter is going to be superimposed over the femoral neck in a lateral. You're going to see lesser trochanter, the proximal third of the femur. You see pubis, ischium, and a little bit of ilium. And a lateral projection. And this is why you can shield for these patients, for males and females. You don't need to see all of this right here. So you can lay a shield going right down this way and still see everything you need to see on male and female. And this definitely is within that close proximity to radiosensitive areas. So there's your routine. Modified Cleaves method and an AP unilateral hip for a hip. Now, if your patient cannot assume these positions, if they cannot do the lateral frog leg, if they cannot do the modified Cleaves position, then you have an alternative, and it's called a Danelius Miller method, and I'm not sure I'm pronouncing that first name correctly. But it is an axiolateral infero-superior projection of the hip, proximal femur, more commonly called an OR lateral. So if you hear the term OR lateral, this is the projection they're talking about on page 284. And the reason it's called an OR lateral is because many times when a patient goes in for hip replacement surgery, you're going to do post-op x-rays either in the OR suite or in the recovery room. And you're going to do an AP hip, proximal femur, like on page 283, but that patient's still under anesthesia and they've just had surgery. You're not getting them to do a frog leg. So this is what you do in that recovery room. But it can also be done in the department if your patient cannot do the modified Cleaves method. So this is your other alternative. And this is difficult to do. But what you're going to do is you're going to lay your patient on the table, supine, make sure they're not rotated. If they can internally rotate their effective leg 15 to 20 degrees, have them do that. But if they can't, if it's major trauma, then, don't worry about it. Just do it as is. But you're going to have a horizontal central ray. You're going to move your tube to where you've got a horizontal central ray, and you're going to sit your image receptor beside of the patient with the top of a 10 by 12 inch image receptor about the top of the iliac crest. And it's going to be angled out in such a way that the image receptor is parallel to the femoral neck. So it's not right up against the hip, it's not right up against the patient's side. Your image receptor needs to be parallel to the femoral neck. And you're going to direct your central ray perpendicular to the femoral neck, which is also perpendicular to your image receptor. And it's going to shoot right up through the crotch area. So you're going to elevate the other leg, the unaffected leg, you're going to raise it up. Now, whether the patient can hold that or not, it totally depends on the patient. A lot of times they can't. So either you're going to hold it, or another tech's going to hold it, or a family member's going to hold it, but somebody is going to put on one of those aprons and stand there a lot of times and hold that leg. Now, if there's some way that you can manipulate their bed to let them, rest their foot on the side of the bed or something, that's fine. I've seen techs have the patients put their foot on the collimator box. Not an advocate for that for a couple of reasons. One, if you haven't noticed already, sometimes those collimator boxes get really, really hot, depending on your equipment. Other times, when they put the weight of their foot on that collimator box, it moves the whole tube. Again, depending on your equipment. So it's not the best scenario, but it is possible in certain situations. But you angle that tube to where it's perpendicular, central ray is perpendicular to that image receptor, which is also perpendicular to the femoral neck. And it should enter the femoral neck area. Now, the larger your patient is, which this is skinny mini in this picture, but the larger your patient is, the more you need to lift up the unaffected leg to get the extra soft tissue up out of the way. Okay? And this is what you're going to see on the image. You want to see the entire femoral head. You want to see the acetabulum. You're not going to see much past the acetabulum, but you do want to see the entire acetabulum and the proximal, probably third of the femur, if not proximal half of the femur. If this is a post-op, if they've had hip replacement surgery, you might want to just start out with a 14 by 17 inch image receptor, even though your book says 10 by 12. Again, because you still have to get this entire prosthesis. So this can be done for trauma patients in the department, but this is commonly called an OR lateral because this is what you do post-op. You do an AP like you see on 283, and then you do this axial lateral infrasuperior projection. Any questions about that on page 284? Okay. Another special projection that you can do is called the Clemens-Nakayama method. And I think there's a couple of our clinical sites that do this routinely. But this is one of those that's a special projection for trauma. This one can be done if your patient can't do the modified Cleves method and your patient can't lift up the unaffected leg. Maybe both hips are hurt. Maybe they've had some previous surgery where they've got very limited range of motion of the hip that's not hurt today. For some reason they can't lift up that unaffected leg. So this modified axiolateral is what you can do in its place. You're going to lay your patient on the table, and you're going to scoot them over as close as possible to the edge of the table. Because what you want to do is you want to put that image receptor. You're still going to have almost a horizontal central ray, but there's going to be about a 15 to 20 degree angle posteriorly. So it's going to be angled posterior to the patient's body. You want to put that image receptor, because of that posterior angle on the central ray, that image receptor needs to be below the patient. So in this aspect, you can use the Bucky tray to hold your image receptor. If you're doing, which this is the right hip, if you're doing the left hip, you can scoot them all the way to the other side, and if you have a table or something that can hold your image receptor, that's fine. Or you can flip the patient around, which I don't suggest, but it's an option. You can put their head at the feet and the feet at their head, where their left hip is over here. So you've got a couple of different ways you can do that. But you're going to use about an 80 to an 85 kV range. You should have a grid on this image receptor. So still about a 16 mass. You still want the central ray to enter the femoral neck area and be perpendicular to your image receptor. And this is what it looks like. Looks very similar to the OR lateral. It's just not quite as lateral. It's a little bit oblique, but that's okay. But you want to see the entire acetabulum, the femoral head sitting there, the femoral neck, and the first proximal third of the femur. So this is what you can do for trauma for the modified axiolateral hip. If you can't do the modified cleaves, if you can't do the OR lateral, you can do this in its place. But again, there's a couple of our clinical sites that do this as their routine for trauma. Okay, let's look at some images. What's wrong with this? When you look at this image, if this is an AP pelvis, what's wrong with it? It's the first thing that jumps out at you. Lesser trochanters. It's not necessarily tilted. I know these iliac wings look a little bit foreshortened, but they both do. They're both symmetrical. The obturator foramen is pretty much symmetrical. So they're not necessarily rotated. The sacroiliac joints appear symmetrical, so they're not necessarily rotated, but you see a big lot of lesser trochanters. So what did they do wrong? No internal rotation of their leg. And that's a repeatable error. If this is supposed to be, as it's labeled on this slide, a unilateral frog leg, they're way off. A unilateral frog leg is what you see on page 285. You only see one instead of both or the entire pelvis. You see this fracture here. If this is a bilateral frog leg, they've not frogged enough. It just looks like the legs are in neutral position.
Hey, Christy.
Yes, ma'am.
I think they got that one mixed up with the next slide. I think the next one
Possibly.
must be the unilateral frog leg.
Possibly. If this is an AP pelvis, they have done a couple of things. They have clipped a little bit of the iliac crest here with the name blocker from an old film screen. So they've clipped a little bit right here, so they're going to have to repeat that. But they've also not internally rotated their legs. So depending on what this was supposed to be, there's several issues either way. If this is an AP pelvis, it's still a repeat. They've clipped this right here, and they've not internally rotated their legs. The lesser trochanters. So this is a neutral rotation of the leg. Bilateral frog leg. And this is a child, obviously. You still see major growth plates open here. Tell me one thing that's repeatable.
There's no marker.
There's no marker. What else? Yeah, this is what this patient, and if this is your book says this is a 2-year-old, I mean, I can tell by looking at it, it's a young child, then somebody's most likely having to hold this patient down, and this is something you need to look for when you're doing patients where you have to have somebody help you hold them, is where are their hands? Where are they in, you've got to make sure that they hold them, yes. But they've got to hold them where they won't get their hand in the way. So somebody's holding this kid down, but they've put their hand right over this left proximal femur. What about the gonadal shielding?
I think it fell off.
Yeah, it looks like it fell off. I praise them for attempting to place a shield on a kid, but either it wasn't correctly placed to start with, and a 2-year-old may still have on a diaper or a pull-up, so it's going to be difficult to, and if somebody's tried to hold them down, then they're moving, they're squirming, so they did, even if they did place it correctly to start with, they did not secure it, either by taping it to the diaper or what have you. Okay. Chapter 7 homework is due on next Tuesday. I did grade discussion boards. I think I'm caught up on those unless you've submitted something on the last one in the next couple of days. The third discussion board, I sent out an email yesterday, is open. Your replies are due today. The second discussion board, I put several comments on a lot of your all's initial posts and even a couple of your all's replies. And some of them I emailed directly to the author, but most of them I just put in the comments in the feedback section to when I graded it. So make sure you look at that. If you have any questions about what I said, just let me know. Some things I hope I cleared up for some of you guys, but if you have any questions, let me know. You guys have a wonderful Thanksgiving. I'm done a few minutes early, so you guys have a few extra minutes. For those of you guys watching this on recording, if you have any questions about anything that I went over today, send me an email. I will check it from time to time over the break. I won't check email every day, but I will check it, and I'll be back in the office on Monday. So if I haven't answered you by then, I'll answer you next Monday. So you guys have a wonderful break and a wonderful Thanksgiving with your family.
If we do lab at 11, about will that put us on?
Again, I want you guys to take as much time as you need with Mr. Lowe, so if we have to start it later, we can. That's fine.
Hot water heater is like so for you. Okay, I just have one.
Hi, Brent. Hi. Brady, you look so good.
We missed you.
I miss you all.
I miss you. Can you hear me?
Yeah, I miss you.
What?
I said I miss you. Can you not hear me?
You're turned down too low for us to hear you.
I said I miss you.
Can you hear us?
Yeah.
Oh. Well, you look pretty. You look really good.
Thank you.
Happy Thanksgiving. Production of Radiology Class requires what being part of fulfillment. I'm putting heat to boil off of it. Is that all? Would you think? I don't either.
Area feel better? They only had one left and it was a large, so it's really big.
Wait, how many ones? I think little things are bigger like that.
Isn't it like the best?
love it.
Not yet, that's what I'm going.
Hair color too. Look at all those. I love your highlights and haircut. I'm still iffy about the bangs. Why? I feel like I feel like sometimes look like John Lennon, like the Beatles. I don't know.
Did you folks have any worse weather last night?
No, I mean, I'm down over by Kingsport, and we just had the ice and that, that bad. But I think Brooke she's up in Wise, and she had a little bit more.
Oh, okay.
Yeah, it's still there too, so.
I got text messages.
We're gonna get.
Yeah, me too.
Making appointments like a year.
I know one year,
Like, I hate that.
I was headed over here,
I told him, I remember last year.
buzzing right along, from, Route 11, Bristol to Kingsport. Got about halfway along and I noticed, all the traffic is, yeah, zip, 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 zip. And of course I wasn't flying, but I was making better time than was. All of a sudden I felt, the bank coming around and I said, wait a minute. So I let it drift and slow down. And it was nothing but a sheet of ice.
Yeah.
I'd much rather have 3 inches of snow
Oh, I know.
as a glaze of ice.
Yeah.
That's so important up top, doesn't it? That goes.
Well, mine is missing. I don't know if I left it. I read for here last week and next week. I left it, but I did go back to the office to drop my books off, but I didn't see it.
I did. Piece of shit. All of you now that I came over with the express reason of meeting with you, all wanted to meet. I didn't do another spreadsheet.
Oh, okay.
I just-
Wow.
Are you cold?
Does elbow work?
Yes, but it's.
Okay.
That's all I'm gonna say.
But, it works good. Yes.
The end.
Every time I use it, I just have a little bit and. So, if you use it, you look, you're going to. Our whole rule for the rest
Yeah, I saw her. I did see her. Okay. All right. We got some time. I hear myself echoing. Is that too close?
I heard from a couple of the Virginia High people that were going to be there around 9:30, hoping that they would. But I assume that people will. 9:30 around 9:30.
I wouldn't think they'd have a trouble with 9:30, but I don't know about that either. So. You folks didn't have any trouble this morning?
Get out of bed was something.
Getting out of bed. Yeah.
You're hoping?
I am. I like the snow.
I don't mind snow. I just gotta drive it tomorrow morning.
Okay.
2 in the morning.
That's tonight.
That's tonight.
That's tonight. That's not the one. 2 a.m. is tonight.
When I have
I'm
to
gonna
go to
get
work.
stuff to work tonight.
And I gotta worry about drunken semi-truck drivers.
Yeah. I like the snow too, and I don't mind traveling in snow as long as everybody else stays home.
No one else, right?
It's like, my dad taught me how to drive in snow, so I'm comfortable with it. It's the crazy people that don't know how to drive in it,
Right.
that like slide everywhere. There's a hill in Wise. Me and my dad went to see a movie last year, and he went down for real or in the movie, and it was like completely wide outside. And there was a car just sliding backwards down the hill. They were stopped on the hill, but they just slid backwards all the way down. I was like, because that goes to a hill.
Yeah.
That'd be
What
odd.
was
So
that one
street.
off the hill?
It's like in Big City, like right there. Right there at the hill, and you could see everything. Right off right there.
You can ignore me if you want to.
I ain't even looking at it. I'm still on there, right on my road, like sliding down the hill. It's all.
Nobody can see you.
Buffalo, New York, where they get nasty stuff. In the wintertime, in the summertime, they get nice cars. You know, I'm talking like Cadillacs, they drive nice. Wintertime, you go out, there's a beater, $200 car, and they slide out, they get a guardrail, they don't care.
Highlands and Withville are both on snow schedule, so yes, they got to sleep in.
Things all rusted.
This is one of the caveats with the
That's what you do, you know, you don't
Fort
put your
College
good cars
system.
out in the snow.
My dad was in Pennsylvania last winter, so he's like super excited to be back here because he's like, it's gonna be so much warmer.
So right here, we just have one vehicle.
Yeah.
If it gets rain, it's good.
Yeah.
That's pretty much it.
I reckon the snow one time I don't drive it no more.
What'd you do?
I got stuck in that snowstorm like all night. I mean, I got stuck for like hours. You know, 2009 when they had the
Oh,
big
that one you did?
snowstorm.
And what happened in 2009?
The big snowstorm we had,
What about it?
I got stuck.
Treated mine.
It took me like 4 hours to get home from a 30-minute drive.
Some old guys got it right.
From a 3-hour tour?
Well, I
Did you
decided
have
to go,
Gilligan with you?
I decided to go shopping that day,
Uh-huh.
and then I was in Johnson City, but then I like went back.
That was your first mistake.
That big snowstorm we got last year, I got stuck in Duffield for like 6 hours. Some truck
It
jacked
took
me.
forever to get home.
Oh, the big creek that turned.
I was stuck in my bed.
Old.
I was stuck at work for
Go to Frank last
No, I had to
night.
I don't know anything to eat though.
I'll take copies of it.
All the way back to Live. No problem. Driving, but we got home and couldn't pull in our driveway. When I'm 16, it's the only time when he's driving and couldn't pull in the driveway.
Hey, did you see that number?
Oh, for her.
About that sample? That's the only thing I hate about.
Oh, yeah, I didn't get a chance to call it.
Yeah, you should.
What do? You just call it?
Yeah, he starts talking.
Is it interactive?
He's like coaching this big story now because
Okay, good morning, folks. As you are already aware, Virginia Highlands and Wytheville are on a snow schedule. And I don't know, Wytheville, if any of you dared entering the classroom early, let me know.
I'm one of those.
Highlands, do the same thing, please.
Dawn, I'm here.
Oh,
It's
okay.
Emily.
Emily, good morning, Emily.
Good morning.
Are you the onlyest little engine there?
I am right now.
Okay, well, that's fine. I mean, you didn't need to be, but I appreciate you making the effort. And since this is being taped, I'll just say for the benefit of the Wytheville and Virginia Highlands students, I will send you the link as soon as it's posted and I have access to it. So, unfortunately, this is one of the negative aspects of having a four-campus program, especially when weather becomes an issue. But we deal with it by using those taped presentations. Now, I know some of you have benefited from the taped presentations. So, has everything worked okay? No? Okay. What has not worked for you?
Oh, it says file corrupted. It won't play. It starts out playing, but it sounds like really like elongated, like you talking.
Okay.
And then it just like for a few seconds it stops.
Okay. Is that opening from itself?
Well, no, because it was spaced in the link, like my HTTP, and then it was spaced, and so I couldn't click on it.
Okay.
So I had to copy and paste it.
Okay. That's what I suggest, is copying and paste it in your browser and opening it that way. But you still had difficulty with it. Okay.
Mr. Lowe,
Yes, ma'am.
I could not get my video from Thursday's class, but I missed a play either. I couldn't get it on any kind of, I tried it on every player I had on my computer, and I couldn't.
Okay. And likewise, were you attempting just to double click on the link, or did you
No, I
copy?
copied and pasted it to
Into your
Firefox
browser.
and everywhere else.
Okay. Okay. Well, when you have those situations, let me know. I mean, I was unaware that you were having difficulty, but and I'm saying this for everyone who is not in eyeshot of me, because you will be in earshot. If you have difficulties, let me know, and I'll see if there's any way of cleaning it up on the origin end, and then attempting to send it out again. But we will tape the session, both Christie's and this class, okay? And it will show up probably as a single link. So both classes are back to back. You can accelerate through it with a little drag bar at the bottom, but both classes will be on the same link. I have disabled the test that I was going to give you today. I think it's unfair to have everybody take it and not have a full lecture behind you. So instead of favoring some and not, I will just postpone it until Tuesday. I do know, and I'm not sure I'm talking to all of you, but I do know that some of you, because of the circumstances, Tuesday did not, let's see, today's Tuesday, last Thursday, did not take last Thursday's test. And so I will be sending out an email and open that up for you. If I can get in touch with those 2 or 3 people, I may open it later today, okay? But I'll take care of that with sending out an email letting you know. Southwest, you're a little bit fuzzy because I'm looking at you at a distance, but you're behind me and I can see you more clearly. We are missing folks there, aren't we?
Yeah.
Okay, let me know who we're missing on the Southwest campus.
Brittany is on another campus. Brittany is at Mountain Empire.
She is.
Are you there?
No, she's not here.
Yes, she is.
Okay. That's who that blonde is. Okay. Who else are we missing?
Sarah's in Donna's office.
Abby.
Abby and Candy are not here.
Okay, Abby and who?
Candy.
Candy. Okay. Okay, very good. Well, we're going to continue with chapter 5. And I'm going to back up like I normally do and have a little bit of overlap. And I'm not sure exactly what slide this is, but remember our discussion last Thursday dealt primarily with the anode, and we got into spatial resolution. And the way that we want to remember the anode and its effect on spatial resolution deals with the focal spot. As you can watch as I fill in the PowerPoint, the filament wire, whichever filament wire we select, if we have a dual focus tube, determines the area that we're going to be using on the anode face. The target, if you will, is a term that's commonly used, and that would be the actual focal spot on the anode face. But then if we draw lines perpendicular to that towards the image receptor, we would be defining the line focus principle and determining the size of what we call the effective focal spot. So you can see the geometry behind that on this slide. And if you have this slide and you wanted to just put in your margins, this is essentially the line focus principle. Now, the effective focal spot doesn't represent the entire area of exposure. All that the line focus principle does is define resolution. Okay, so we followed this slide with another slide, and in the slide that just popped up, what we're doing is comparing the size of the actual focal spot and the resulting effective focal spot based on size. And we determined that the larger the filament being used, the filament wire, we're going to use more area on the anode face, which means a larger actual focal spot. And if we're using a larger actual focal spot, it's going to result in a larger effective focal spot. Okay? And if we have a larger filament wire and a smaller filament wire, and we're doing an anatomy where we want to see the highest spatial resolution, which one of the two would you select? If your goal is to get the highest effective, the highest resolution, spatial resolution,
All focus spot.
you would select the small focal spot. Now, know that there are some limitations, but you have to go. That is the correct answer. Okay, but you may be doing an anatomy that requires more radiation than a small focal spot will carry. Okay? So you may have to go to a large focal spot, knowing that you're going to give up some spatial resolution because of the need for more radiation. Okay? And that's understood. Larger body parts, normally you sacrifice spatial resolution. But small, intricate, detailed anatomy, nasal bones, fingers, wrists, you can use the small focal spot and get the best resolution for that particular anatomy. The other concept that we talked about that affects resolution is the target face angle. And in this slide, you can see that the one to the left demonstrates a 30-degree angle, the one to the right a 15-degree angle. And if we follow the geometry behind these two options, we see that the face angle that is less, okay, 15 degrees in this case, which would also be considered more steep, okay, or steeper, is going to give us the smallest effective focal spot, and again, the greatest spatial resolution. So, make sure that you have those two straight in your mind. There's a third concept. It was presented in your book, and we looked at it back when we were, I'll fill this one in and then go forward. A couple of the other, since we're on this slide, a couple of the other pieces of information would be that X-ray tubes are usually between 5 and 15 degrees angulation, okay? 12 degrees is probably the most common, and the ideal thing or the important thing about 12 degrees, it takes at least a 12-degree angle to cover a 14 by 17 at 40-inch distance. Now, certainly we talked about options concerning that, but that is a rule of thumb. Okay, that is a principle that you could see in the form of a question. And then we talked about NEMA overseeing the accuracy and the projection of or production of X-ray filaments and determining their size. The third thing that I want to bring to your attention is blooming. Okay, on page 66 in your textbook, there's a little blurb there on blooming, and I wanted to make sure that you understood what we're talking about. So I'm only using the large focal spot here. Okay, so if you would consider that you're selecting a smaller MA on the large filament. Okay, and when we say that, we're talking about probably anything bigger than 200 would probably energize the large filament instead of the small filament. So it's your selection of MA. I think that I suggested if we select 200 MA, when we get ready to take the exposure, we're going to cause heating of that filament wire. But, let me play that again. Let me play the first part again. Look at the area that 200 MA would utilize. Okay? It is not the highest MA station that you have available to you. And so, it may incorporate the entire wire, but it's not going to heat that wire to the same excess as if we chose an 800 MA station and got this result. Okay? I think when you look at both of those options, Both of them are on the large filament wire, okay? But 200 MA would heat the filament wire to a lesser degree. There would be fewer electrons made available at the site of the filament wire, space charge, thermionic emission, okay? Plus, we would be using a smaller portion of that filament. When we use a higher MA again, okay, just so that you make sure you make the connection, we're going to get higher heat, more blooming, more spread of those electrons, and more electrons. Okay? And so that in itself, blooming, does affect spatial resolution. We're going to talk about off-focus radiation here in just a few minutes. And so off-focus radiation is also going to apply, but this is blooming. It's the comparison of the heat being placed on that filament and the increase in the size of the thermionic cloud that's emitted. So any questions about thermionic emission and how it relates to blooming? Okay, very good. So, what would be the summary there? The higher the MA station, more electrons, more heat, increase in size. And so how would that affect spatial resolution? Decrease spatial resolution as you increase MA. And the same would hold true on the small focal spot. I used the large focal spot as our example, but remember on your small focal spot, you may have the option of 25 MA, 50 MA, maybe 100 MA. Well, same thing. If you're using a 25 MA setting, you'll have less blooming even on the smaller focal spots. Okay, so just use blooming in general. It doesn't really matter which filament wire you're referring to. The higher the MA, the lesser the spatial resolution. Okay.
So you use a very high MA and a lower KVP.
If you were using a very high MA and a lower KVP, blooming is certainly going to be a factor, but put that in the form of a question.
I was just reading the last sentence under focal spot blooming in the book. It says, focal spot blooming is important only with very high MA values and lower KVP settings.
Okay. Yes, because you could offset that to a certain degree. Now, it's not always as easy as that makes it sound. You can't just increase your KV and decrease your MA station. There are occasions where you can. Okay, but and really, you don't always have to associate blooming to your KVP setting, even though that is not an incorrect statement. Okay, but don't confuse yourself by relating blooming to KV. Blooming is strictly determined by the MA that's being used for a set of factors. Okay, we looked at that. We looked at resolution across the image. I'm not sure I want to go through all those slides again. We talked about the Hill effect. So any questions on the Hill effect, the distribution of energies, and then what it might look like if we did see it demonstrated? Chances are, if you're not using anything shorter than 40-inch SID, you're never going to see it. Your eyes are never going to be acute enough to pick up on the fact that there's more density towards the cathode, less density towards the anode. The only time that you may experience this would be with the largest image receptor size at a reduced SID, let's say 30 inches or less. Okay? But the theory still remains. Okay? Whether you see it or not is one thing, but the theory is a proven theory. So we have to always accept the fact that there's going to be more intensity of radiation on the cathode end of the image receptor, less on the anode end.
Mr. Lowe.
Yes.
This is Morgan at Virginia Hollins. Me and Candy and Ken are here now.
Okay, thank you. Okay, and we went over this slide. I hope that this made sense to you. We'll just go through it one more time. Remembering that, this is at 72 inches. We're using more of the central rays to produce the image. You would not see the Hill effect present itself here. But if we shortened the distance to 40, we would be using more of the spread of X-rays, the divergence of the X-rays. Likelihood is you still wouldn't be able to see it, but if you used a shorter than 40-inch SID, you may start to see the anode Hill effect present itself and also be visible on a given exposure, because you're using the extreme of X-ray production through the window of the tube. Extrafocal radiation. This is, we'll start with this today as new information. And all we're going to say about extrafocal radiation, or when we say extrafocal, we're saying off focus. So make sure that you understand it to be the same piece of information. Extrafocal or off-focus radiation is simply radiation, X-rays, that are produced within the X-ray tube other than at the actual focal spot. Okay? Remember, there's a lot of components. There's a lot of metal in there. And I think the next slide, no, I didn't. I started to say that I moved a slide down, or a duplicate slide for I didn't think it was that far back. Remember when we talked about there we go. When we talked about isotropic emission, the fact that we have radiation going off in every direction, 360 degrees, and the only X-rays that we're actually using or is considered useful are those X-rays that make it out of the window of the X-ray tube proper and through the collimator box. Everything else is going to be absorbed by the lead and the oil and the glass making up the X-ray tube. Well, also know that we may have electrons from the filament wire that are accelerated across by that voltage, and they don't hit right on what we would call the area called the target. They may hit the edge, the rim of the disc. They may hit more towards the middle of the disc. And so that's going to change all of these angles. And that's what we're referring to as extrafocal or off focus. It's X-rays that are not going to be produced exactly on the target angle, the focal spot, the actual focal spot of the X-ray tube. Now, they're not going to be as numerous as useful X-rays, but they still do exist. And so we want to make sure that, that we do discuss them and define what is likely to happen if we have those off-focus X-rays. It does result in a loss of spatial resolution. Okay? It's like using a larger focal spot. There are some of those X-rays that will be intermingled with the useful X-rays, so it does reduce spatial resolution. It will extend the size of the focal spot, if you will. Most of these X-rays, if they're not produced right on the target tungsten, if they're produced on some other softer metal, it will produce a less energetic X-ray that may add to patient exposure. If they're less energetic, they're less penetrating. Okay? And so they may result in an increase in patient exposure. And because of their angle that they leave the X-ray tube, they may also reduce image contrast. Here's an example of an image demonstrating extrafocal radiation. Now, you can see that we're doing nasal bones here. So, if you're trying to identify the anatomy, it's the right and left projection of lateral nasal bones. Okay? And you would think they're so small, why would you have to do right and left? Well, you're trying to define as best you can. So nasal bones, and we're not talking about all of the anatomy that we see here. We're looking specifically at this area right here where the cursor is moving, and right here where the cursor is moving, the very fragile nasal bone proper, okay? It's easily broken. We would do this with a small focal spot because that's a smaller bone requiring higher resolution for the physician to make a determination of fracture. But what is important about this image as far as extrafocal radiation is you can see some of the shadow of the forehead and some of the shadow of the mandible for both exposures, okay? And in order to produce this image, when we took the right lateral, we had the half of the film covered with a lead blocker, okay? And after we took the right exposure, we moved the lead blocker over and covered that side of the image receptor, and then turned the patient into a left lateral and did the other exposure. So that's the reason that you see a rather distinctive separation here in between, but this imagery outside of the collimators was produced by extrafocal radiation. So you'll very often see extrafocal radiation or off-focus radiation if you are not exposing the entire image receptor to radiation when you expose it. Okay? Because it's not just in the head that it's going to exist. You'd see all-focus radiation if you were doing an elbow, if you weren't exposing the entire elbow, or a shoulder, or especially a larger body part. Now, we haven't gotten to the point yet. Now, Miss Christie may have introduced you to what's called scatter radiation, and a lot of times people will accredit what we're seeing in this image to scatter radiation, and we can't say that some of it is not caused by scatter, but it's a combination of scatter radiation and off-focus radiation. When you see these less dense areas of exposure outside the collimated area. And so you might be asking, well, where's the collimated area? You know, what's he referring to as collimated area? This distinct dark line that you see right here and right here and down here in the maxillary mandible area, this distinct separation of very black. There's no anatomy out here, so the image receptor is turned black, jet black, okay? But you can see down here, it's a shade of gray. Well, this separation of that very black and that shade of gray is the edge of the collimator, okay? So some of this extrafocal radiation is also due to the accuracy of your collimator to eliminate radiation. But this is not unique. You will see this. And you'll see this no matter if you're using film screen or if you're using digital capture. And we'll talk more about it when we start to differentiate the two. So, you know, just remember it's radiation that's produced somewhere on or in the X-ray tube that may not be part of the actual focal spot proper. Okay, so, you know, if we're talking about collimation, let's make sure that you understand where the collimator box attaches to the X-ray tube. There is the first set of collimating shutters. And these are kind of, these are conical in shape. They overlap each other. And the top of these lead shutters form a tighter circle than the bottom of those same shutters. So they are cone shaped. And they extend up into the housing so that they're almost in contact with the window of the X-ray tube. So that's the first collimation that exists. And then you really don't change the cone collimators at all when you collimate. Your action of collimation is to change the leaf collimator. And this just shows from right to left or head to foot, as it will. But know that you've got a comparable set of shutters that is going from left to right whenever you turn the dial on the side of the collimator box, and it either makes your lighted area of exposure larger or smaller. Okay? And you know that you have lengthwise and crosswise collimation. So collimation, definition of collimation, it restricts the area of exposure. So, any questions about off-focus or extrafocal radiation? let's look at tube failure. You know, we made hint of it last Thursday that an X-ray tube is likely to experience failure over a great number of years. If we use it properly, if we don't abuse it, an X-ray tube can last 20, 30 years. Now, if it's a high-use tube, if it's the only room in a very busy department, chances are it's going to last a good, 15, maybe 20 years if it's properly used. So it's not going to burn out in a matter of months or a matter of 2 or 3 years. It'll last a pretty good time. But the greatest destroyer of an X-ray tube is heat. Now the book, if you've read chapter, you've read the information that says that whenever you produce an exposure, 99+% is heat. Actually less than 1% of the energy is X-ray energy. Okay? Now you're thinking, well, then how do we ever get enough? You got to remember that, you're producing a blue million gazillion X-rays. Okay? Plenty of X-rays for the anatomy that you're trying to expose. And if it's a larger anatomy, you produce more than if you're doing a small anatomy. So don't really worry about sheer numbers of X-rays. We don't ever count them per se. We get in the ballpark by saying we're using a certain amount of mass. And all that tells us is we're using more radiation or less radiation for one anatomy than we are the other. But sheer numbers we don't worry about. But 99% of the kinetic energy exchange is going to be in the form of heat. Okay? Only 1% is actually X-rays. So I think you can easily accept that tube failure is because of the wear and tear based on heat to both the filament wire. You know that we heat the filament wire to release electrons. But when you accelerate those electrons into the target material, you produce tremendous heat in that target material also. Remember, that's one reason that we make it spin during the exposure, is to dissipate the tremendous heat that is produced. So if heat is the culprit, what are some things that can happen? First of all, let me show you what a brand new shiny anode face looks like. And I know it's not a very good image, but I think you can almost tell that the focal track looks like a mirror almost. It is a precision of tungsten and almost takes on a mirror. But after we expose that to several hundreds or several thousand exposures, here's what it looks like. Now that's a close-up, but this area that you see right in here, that's the focal track. And it's already roughened because of the heat. The bombardment of electrons striking it, the heat causing parts of the metal to be removed. And, I think I showed you the anode disc that I have on campus, and you can actually look at it, and it looks like little, like a cracked eggshell. You can almost see little cracked ridges in it. But, here's a brand new one. Here is the anode face after it's been used in several thousand exposures. Okay? Now, what are some of the, I didn't mean to do that. Close that. If we have a breakdown in the bearing, where the anode actually rotates, it rotates on ball bearings, okay? When those ball bearings start to wear away, we start to get dragging. And when the disc is not spinning as smoothly as it should, then we start to see that we're hitting areas with more of the radiation than normal. I'll point out with the cursor this area right here. It looks like a big crater. And probably the X-ray anode froze.
Hey, Don,
Yes.
I'm sorry. We're getting like a lot of noise on our end or something.
I think it's folks coming in on the Whitful campus, so,
Okay, I just couldn't hear you for a second.
okay. Look at the crater, and that would indicate that the anode face froze in that position, and several exposures struck a stationary anode, okay? But you can also see that there is pitting, okay, all along that anode face. We're only seeing an arc of it, but you can see that there's quite a bit of detrimental result from the fact that bearings were going bad. Okay. The last thing that we can look at is we might even have a separation of metal. Remember, we talked about a tungsten target embedded in a rhenium or alloyed with rhenium, and so you can start to see that heat is separating part of that alloy, part of that embedment of tungsten. And then if we back up here, we see probably the worst thing that can happen, and that's a cracking of the anode face. Okay, so, all of these things are due to the tremendous heat that's produced. And so we're going to look here shortly at what you can do as a technologist to prevent some of this from happening too early in the tube life. Hold this image in your head, okay? And I think this one actually came straight out of your textbook, page 68. Okay, so turn to page 68, and this particular damage probably occurred on a day much like today, where in the morning the technologists came in, they did not use proper protocol. The ER had an automobile accident and they were sending patients over, so the technologists took a patient in, positioned them for a lateral lumbar spine, first exposure of the day on a cold anode. Okay? Now, remember, this thing heats up, but it's sitting there at room temperature overnight, and so it's at probably 70 degrees, 75 degrees maybe, Fahrenheit, room temperature, and the first exposure of the day that's placed on it increases the temperature of this metal to 3,400 degrees Celsius. Okay, that's a tremendous shock to the metal, and it stresses the metal to the max, and we get a crack in that anode face. So how do you prohibit that? There is what's called a warm-up protocol. Now, every department has their own. I have suggested in this slide what might be a proper warm-up protocol. And the only thing that you need to understand, you don't have to memorize these numbers. Okay? That's the point. What I want you to understand is when you walk in first thing tomorrow morning, okay, and you're getting ready for the morning's work, somebody should be assigned to go into each x-ray room, turn it on, and we know that it warms up, all of the electronics warm up when we energize it with electricity, but we're not putting any electricity through the anode until we take an exposure. So we do this warm-up procedure, maybe 2 exposures at very low exposure values. Maybe a 100 MA station at a 1/10 of a second, which is a very short exposure, at 70 kVp. Okay? And that prepares the metal for bigger exposures. Okay? So we do 2 at that setting. Then we follow that up with 1 more exposure, and we increase our MA, we increase our time a little bit, and we might also increase our kVp. What does this do? It warms the metal slightly more. And then we take a final exposure, 300 at a half a second at maybe 90 kVp. And that warms the metal just a little bit more. And that's all it's called, is a warm-up protocol for the X-ray tube. And it's to prepare the anode target for the high temperatures that are going to be created when bombarded by electrons. Okay? And it eliminates this as a result. Okay? This tube may have otherwise had another good 10 years, okay, of usage. But because of one act of poor judgment, the whole tube has to be replaced. And, you know, at the tune of somewhere between $15,000 and, you know, $50,000. And, you know, the way healthcare is going these days, departments don't want to incur those costs on a monthly or yearly basis. So following the proper protocol and warming it up, which leads us to rating charts, tube rating charts. There are some examples in your textbook. I sent you, I don't know if anybody opened your emails yesterday, but I sent you a Jing taped presentation, okay? It's, I'm not bragging on it. It was just factual information that I decided to send out knowing that we were going to be covering similar things today. If you didn't view it and you want to, it's under your course and it's at the very top, okay? And all you should have to do is double click on it and it'll open. It's like a 5-minute presentation. But it was based on tube rating charts, and that's what we're going to cover right now. You are probably not going to see the tube rating charts. Hopefully you will. You know, when you go into the clinical setting, hopefully they will, you know, want to show you, you know, what they do as far as protocol for warming the tube and making sure that the tube is not misused. But I would dare say that they're not. Okay, they're going to depend on you knowing that there are some limitations. And there are some modern electronics on the new X-ray units that will assist you. If you set certain MA, KV, and time, and then try to take exposure, if the anode does not start turning, and how do you know that it doesn't? You listen for that little spin, that whine that you hear. Okay, hopefully all of you have experienced it. Or somewhere on the control panel, there is an area that'll come up, usually in red letters, okay, and it'll say overload or tube failure or no exposure. There are safeguards to safe use of modern equipment. Older equipment, these may be disabled or they may no longer function. And they may allow you to take an exposure where, another machine would not allow you to take an exposure. And the other thing that I want to say this is every X-ray tube has its own tube rating chart. So you can't use one chart and think that it fits all X-ray tubes. You have to find a chart that accompanies that X-ray tube from the manufacturer. Okay? Now, we're going to be talking about a generic chart. And I'm not going to use the one in the book right now, but I'm going to come back to it in just a second. But why do you want to use these? So that you're not abusing the tube, so that you're not putting more heat onto those components within the X-ray tube that might result in failure. So, this was in your PowerPoint. I gave you these 4 charts. And this was what Jing was based on, if you saw it yesterday. And on this, if you just look at it and don't break it down, it's too much information, okay, TMI. But really, it's just 2 different X-ray tubes. The 2 charts over here on the left-hand side is an X-ray tube. The 2 charts over on the right is a separate X-ray tube. Now, let's look at the 2 on the left. We can see that these lines run through the chart differ. Okay? And if we start really concentrating on the numbers, we see that the one on the top has a 100, 150, and a 200. Okay? But in the little box right here that I've outlined in red, if we read that, it says 3,400 RPM. What's that referring to?
That's the anode.
Very good. How fast the anode rotates during the exposure? It's 3,400 revolutions per minute. Now that's pretty fast. Okay? That's pretty good speed. Why is it rotating? Yeah, to dissipate the heat. To help it get rid of all the heat that's going to be produced in that tube head. Okay? Or in that disc of tungsten metal. Okay, let's compare that to, let's finish the box. The one on the top. It says it's 3,400 RPM, but it says it's 1F. Okay? It is a single phase. 0.6 millimeter. 0.6 millimeter spot. So we're using the small filament. And it's got an 11-degree anode face angle. Now, I know if you're looking at it for the first time, it'd be like looking at a foreign language. But that's really the pertinent information for an X-ray tube. Let's compare that one to the one at the bottom. Red box, 3,400 RPM. That means it's the same X-ray tube. But this one is a single phase. And look at the size of the filament wire. It's 1.0 millimeters. It's a large focal spot. So this is, on the left, this is the same tube, and it's identifying the two different filament wires. The one on top is the small filament. The one on the bottom is the large filament. If we compare that to the two over here on the right, you see that the RPMs is 10,000 RPM. It's a much higher rated X-ray tube because it can dissipate the heat. And why would you want it to spin that much faster? The spin is only for dissipating the heat. It doesn't make the X-rays stronger. It doesn't give you more X-rays. It's just simply saying, I'm using this tube for more complicated exams, and so it requires greater cooling. Okay? But again, we see that this one is 3F, 3-phase, 0.6 millimeter, so that's a focal spot, and it also has an 11-degree angle. The one at the bottom is the large focal spot for this tube. That's a misprint. That should be 10,000 RPM in that box as well. So if you want to put an extra 0 in there, just so you're not confused later. But 3-phase, 1 millimeter, and 11-degree angle. So the two on the left is one X-ray tube, probably a smaller KW rating, maybe a 30 KW machine. The one on the right is more like a 50, 70, 80 KW machine. Okay, it's a higher rated, more sophisticated X-ray tube. Now, the only reason that I give you these four is because if you're ever tested and they don't just give you one and you know that's the one that they're referring to, they may show you a series of tube charts and then give you questions such as these, okay, and then you have to go back and select the appropriate chart. You know, in this case, look at number A, and I sent this to you all as an email last week, okay? So hopefully you have this available to you. If you don't, I'll read it off the screen to you. But and what we're doing is we're going to use the tube rating charts to determine if it's a safe exposure or an unsafe exposure. So A says that we're going to use 95 kVp, 150 MA at a 1 second setting on a 3400 RPM charts using a 0.6 millimeter focal spot. Well, if we back up here, the only one that fits those characteristics would be this one. So I selected it and enlarged it, and now we're going to fill it in. We said that we were going to be using the 150 MA selection, so let's highlight that curve. And it said we were going to be using 95 kVp, so, you know, it's not that well graduated, but let's just guesstimate where 95 kVp may be. And it said we were going to be using a 1 second exposure. Okay? When we look at the convergence of the kV to the time and its relationship to the MA curve, we see that it falls above that line. That would not be good. Okay? That would not be good. So probably your machine would have not let you take that exposure anyway. But if it did, you know, that would cause more damage to the tube than normal. Okay? So, let's look at the next one. If we went back to the question, I'm not going to flip back and forth because I've got them printed out here. B says that we're going to use the 400 MA station. So let's highlight that curve. We're going to use 85 kVp, estimation there, at a 0.5 or a half a second exposure. Okay? Now it goes on to say that we're also using the 3400 RPM and the 1 millimeter focal spot. So, we can see in the little box here, we've selected the correct chart for these exposure parameters. Now, look at the convergence again, and we find out that it falls right on or very near the MA. That would be considered an acceptable exposure. Okay? If it falls right on the curve, consider it acceptable. Okay? Remember the one previous, it fell above. That's not a good exposure. You wouldn't want to expose the X-ray tube to that much. This is an acceptable exposure. Okay? So let's go on to the third one. And what I did yesterday, and unknowing, I think I went back and looked at your copy of these, and I already had them filled in for you. So hopefully you did it on your own before you realized that they were already filled out in your PowerPoint. But the third one says that we're going to use a 1 millimeter, 10,000 RPM. Okay? So we looked at the information box here, 10,000 RPM, 1 millimeter. We got the right chart. And we're going to determine whether on a 500 MA station, if we could use 125 kVp at 1/10 of a second. And the answer is yes, we could. Okay? And all we're doing here, let's don't complicate things. You have to read the question, you have to determine the parameters of the exposure, and then you just have to plot them against the chart. Okay? And since this convergence of kV and time falls below the MA curve, this would be an acceptable exposure. D. Okay? D says we're using, again, 10,000 RPM, 1 millimeter focal spot. But this time we're going to be using the 700 MA station. Okay? And I didn't try to curve a line. I just used a straight line. But that's cutting through the 700 MA, that yellow line labeled 700 MA. And you may have to come down here and say, okay, there's the bottom line, that's 1,000. There's the next line, 900, 800. So that has to be the 700 curve. Make sure that you determine the right curve. And we're going to try 75 kVp at 0.3 of a second. Would this or would this not be a safe exposure? Okay, it would be. It would be. Again, selecting the right chart with the information in the box and then plotting the exposure information. Lastly, D says we're using the 10,000 at the 0.6 millimeter focal spot. Okay? On that chart, we're going to be using the 400 MA station at 88 kVp at 1/10 of a second. So that means wouldn't want to do it. Okay. Hopefully the machine would tell you you don't want to do it. That would not be an acceptable exposure. Now, I know you're asking this question of yourselves, and maybe with the intent of asking me. And I'll go ahead and say this. I previously said, you're probably not going to ever see these charts. Not unless you ask, where do you keep your tube rating charts? And somebody in the department knows. Okay? If the machine does not indicate that this is not an acceptable exposure, by either not letting the anode turn or throwing up that little message, you're not going to know otherwise. Okay? And the point is this: for test purposes, for your knowledge of how an X-ray tube works, you need to be able to determine if exposure parameters such as the ones that we just worked with, okay,
Hey, Dawn.
are safe or not safe. Yes, ma'am.
Oh, sorry. I was, over the weekend, I was like looking in the book at that chart, and I was trying to figure out how they got like safe and unsafe on
Yeah,
figure.
I was gonna do that anyway, okay? Because
I didn't
I already
understand C. How they got that was safe.
say again, Chelsea.
I didn't understand how they got that C was safe.
Okay, let's look at the problems that are in the book real fast. And I'm sorry, Elmo doesn't work, so I'm going to be looking at my book. What I would suggest is you get a straight edge, blank sheet of paper, whatever. But we only have one chart, and we're on page 66, the second column there. And then down at the very bottom, you've got 4 problems. So let's just work those problems out real fast. We don't have to choose the select chart because all of them are based on that single chart. So, A, find the point and tell me, is A, well, it tells you there. Dang, nabbit, why do they tell you that it's unsafe? Well, let's find out why it's unsafe. Okay? This is no good at all. It says that we're using the 125 MA station, so that would be the blue line. So over on the left where it shows you kVp, select 100 kVp.
Thank you.
And then the half-second exposure. And when I select 100 kVp, at a half-second exposure on a 125 MA station, they say it's unsafe. I say it's safe. What do you all say? Does it fall above or below?
Below.
Below. That's a safe exposure, folks. The textbook?
That's what I didn't understand because I thought on a lot of these that they were like not what they said.
Okay, very good. I'm glad you asked the question, and I had intended on doing these as well. So let's look at, and does anybody disagree? Does everybody find the point of convergence of kV and time to fall below the 125 MA curve? Okay, then do B. For the 200 MA, we're plotting 85 and not a half a second, but 1/20th of a second, or 0.05. So 0.05 at 85, 0.05 at 85 would be very close on the 200 MA station. Do you all agree?
Dawn.
And I'm going to say that it would fall just slightly below. I think B would be a safe exposure. Yes, ma'am.
This is crazy, but on B and
That's not good.
No.
Okay. Well, knowing that some of you may have text, mine for B, mine says 85 kbp 0.05 at 200. So some of you have the same information except it says 0.07.
Yeah.
Okay. If it says 0.07, I would say that it's unsafe.
Well, it says that it's safe.
Okay. Look at it. Plot points, and I know that a lot of this is guesstimation because it's a small chart, but 0.07 would look like for 85. I can see where it'd be very close. It probably falls right on the line. So whether B says 0.05 or 0.07, I would think that both be safe. So go to C. Plot C and see what you come up with. And my book, or the book that I'm using, says 115 kbp, a tenth of a second on a 200 mA. And you don't have to plot very long, okay? C is, without question, what?
Unsafe.
Unsafe. Falls above the 200 mA curve. So D, get something different? C. It says safe, but look where the point falls.
Unsafe.
Yeah. Yours says unsafe?
Unsafe to see.
Okay. Well, they've made some corrections. I thought, I didn't know that they had a second edition out, but evidently you all have a second edition copy or a second print, if not a second edition. So, you may or may not have one print or the other, and it could change, but,
Is it best to just remember if it's under that MA curve, it's safe, and if it goes
If it-
over, it's unsafe?
if it falls below the curve, it's safe. If it falls above the curve, it's unsafe.
Got it.
And D, just for the discussion, 100 kVp, 0.2 of a second on a 250 mA. If you plot that, 0.2 at 100, it also is unsafe. So, go by your book's details about where to plot them. Make sure that you understand, no matter what the book says, if the point is above the curve, it is unsafe. If it's below the curve, it's safe. Okay. Any further questions on the use of two breaking charts? Okay. Now we have determined that heat has a lot to do with damage of an X-ray tube. And we're almost out of time, but let me introduce you to heat units in closing. Okay. Remember this from chapter 4, and remember that really half wave. Yes, you need to know what it is, but you're probably never going to deal with half wave rectification. Okay. Full wave, yes, there are still units in the hospitals you're going to. Where you're going to be using single phase, full wave, 3-phase 6, 3-phase 12, and high frequency. Remember this, that the more efficient the tube, and when we say greater efficiency, we can say that it is greater efficiency if we have less ripple. Okay, I think you probably understand and remember that from chapter 4. So high frequency is really the most efficient generation of X-rays, okay, because it stays at that very high level for the course of the exposure, okay. It's only about 1% ripple. Single phase, and you can use single phase, but it's probably the least efficient. You're using more energy to produce a less efficient beam, okay? Well, also remember this, and I fill these down here at the bottom. Less voltage ripple, this is already filled in your PowerPoint, but less voltage ripple results in what kind of quantity and quality? Increased, greater, okay? Less voltage ripple, we're talking about high frequency, as compared to any of the others. It is a higher quality X-ray beam. As voltage ripple decreases, tube output efficiency does what? Increases. And as tube efficiency increases, what about the heat to the X-ray tube? It also increases. And this is found on page 67. Heat units. This is the last slide of the day. Heat units are calculated using this formula. It's very simple. It's the MA times time times kVp. Now certainly that is for single phase full wave rectification. A times time times kVp. Okay? And so you have to be given all three of those values. But then you just multiply them through. But what if we're talking about a three-phase, 6-pulse type of generator? We use MA times time times kVp times a factor of 1.35. Why? Because it is a more efficient generation of X-ray energy. So it does produce a bit more heat, 35% more heat, as a matter of fact. If it's a three-phase 12, it's MA times kV, MA times time times kVp times 1.41. Now, your book tells you that 141 is also used for high frequency. I disagree. If it's a high frequency X-ray generation, you must use MA times time times kVp times 1.45. For registry purposes, high frequency uses a quality factor of 1.45, not 1.41. Now, if you're looking at the information there on page 67, everything that's on page 67 in the textbook goes along with the quality factors that they're telling you to calculate heat units. But for test purposes that I'm going to be giving you questions for, and for registry, please remember that high frequency is 1.45. And it's just a simple mathematic calculation. And you're not going to have a test today. Some of you that came in late, I postponed the test that was scheduled for today until Tuesday. Okay? But remember this, when you're posed with that question on heat units, you got to remember which one of these generation types that the question is referring to. But one thing that, to make sure that you don't misread the question, is the question may also say that there is a certain number of exposures being made with this 3-phase 6 or 3-phase 12. So don't forget to also multiply by the number of exposures that are being made in the question. All right.
Mr.
Questions?
Lowe,
Before you leave? Yes, ma'am.
are you still going to reopen the quiz that we had last week?
I'll reopen that one. Let's see. Morgan, you, and I think Cassandra, and anybody else on your campus need to take that?
And Janet.
Janet, okay. I open that and make it available today. Can you all take it today?
Yeah, we can.
Okay. I'll leave it open until 10. Anybody
Thank
that was unable to take it because of the confusion Tuesday?
Yes, Dawn.
Yes.
I wasn't able to take it either. I emailed you this morning though and explained, but I will take it on campus today. Are you? So is the other one with the one question that we had, that's being knocked out, right?
Yeah, that. I eliminated that because Blackboard went awry and there's 20 questions. So, but I will make it available today for those of you who did not complete it on Tuesday. Travel safely.
Hey, Dawn.
Happy Thanksgiving.
Dawn. Mr. Lowe.
Yes, ma'am.
Oh, I thought you said just a minute. I don't understand, like, when you said at the end, just to make sure we multiply by the number of exposures.
Yes.
Is there, I don't know, is there, like, an example problem that you can do, or? I just don't, like, when you say exposures, do you mean the 1.41?
No, look on page 60. Look at page 67, the very top, the critical thinking question.
Okay.
It says 5 abdominal films
Okay.
are exposed with the 3-phase 6-pulse system using 85 kVp, 105 mass. Now, where did they get 135 mass?
Where did they get it?
Yeah.
The MA and the time?
Yeah. I mean, in that particular question, they're not giving you a separate MA and time. They're giving you a mass. So it would be mass times kV times 1.35 times 5. Because it's said in the question that there are 5 exposures.
Oh, okay.
Okay? And that's what I was referring to. You know, don't discount that there may be more than one exposure being made with those exposure factors.
All right, thank you.
Okay. If you all don't want to meet with me, you don't have to, but I just wanted to make that available to you, okay?